I want to tell you a few things about Wes Shankland that I know of, and that's just a few things. I think one of the highlights for me was that his freshman year in dental school, now get this, his freshman year in dental school, he brought Hal Huggins to the University of Ohio State, the dental school. He brought Hal Huggins. Do you know how blasphemous that is? He had the audacity to bring Hal Huggins. So I thought that was quite a highlight for a man to do that his freshman year in dental school. He's got a BS in biochemistry and zoology. Now, after he graduated from dental school and was a practicing dentist, he went back and got a PhD in anatomy while still practicing dentistry. Now, that's quite a feat. An anatomist is a person that dissects the whole body and knows all the structure. Totally incredible. Now, I wouldn't say he walks on water, but I think his shoes have big pontoons, at the least. He's currently the director of the TMJ and Facial Pain Center in Columbus, Ohio. He specializes in treating facial pain and jawbone cavitations. He also drives a red car that the bumper plate says, is it the back or the front?
Both in Ohio.
It says Pain Doc. So
Doctor. Yeah. Pain DR.
Pain DR.
Pain doctor.
Now, he wants people to know what he does. He's the author of 90 scientific papers, a manual of head and neck anatomy, and chapters in 2 textbooks. He's really mapped out the trigeminal nerve. This guy knows about the trigeminal nerve. If y'all want to ask questions about structure and about function of the trigeminal nerve, you got the guy to ask right here. He's authored and published 3 books on subjects of TMJ, facial pain, and bioterrorism. I'm not sure about that one. He has a membership of a long list of professional organizations. He's the immediate past president of the American Academy of Head and Neck and Facial Pain. He's taught 120 courses throughout the U.S., Canada, Mexico, Caribbean, Germany, and England. These courses have focused on head and neck anatomy, craniofacial pain, the differential diagnosis of headache pain, TMJ disorders, and most recently diagnosis and treatment of osteocavitations. He's the only doc right now, the only dentist that I know of, or physician or anyone that's teaching a course in how to do osteocavitational surgery. That's quite a feat in itself. It's a 5-day course. It's rigorous, but boy, is it worth it for any dentist that wants to pursue that end. So today he's going to talk to us about diagnosis and treatment of osteocavitations. All right,
Thank you, Ray. Thank you, brother.
Yes.
Good afternoon. I think that Ray's a little hyperbolous, a little exaggerated, but that's all right. I appreciate it. You said just the way I paid you, brother. Just the way I paid you. A couple things here is since Susan did such an outstanding job and Mike covered so much, did a great job, and since Kerrie has made such wonderful organic food, I'm still looking for a Waffle House, but I'll take that organic food. I think we're going to probably do this quickly and adjourn for some organic margaritas. Is that okay? Yeah. I also, with Roy being on there, Roy, I really, really enjoyed your presentation. And with Mike, I am your token Gentile male today. So I'll be talking from that standpoint. Also, Mike, it's the way I say it is. There's no other way. The way I do it's the right way. And you take the highway, brother, I'll tell you. This discussion I'm going to give you today, you're going to see, it's funny. Mike and I have done this 4 times. Mike is a dear, dear friend. I mean, I love the guy. But I tell you, we never talk about our presentations. And so many times, every time we've done this, our presentations have dovetailed as if we sat in the same room and wrote them. That's not the case, but you'll see what I'm talking about. And Susan's was an outstanding introduction to Michael's and to mine. And I think that you'll see, I'm going to cover some things, and I'm going to go pretty fast in some things because you don't need to know some of the stuff I'm going to show because they've already covered it well. However, we're going to talk about some other things, some new concepts that perhaps you haven't heard. I'm not worried about this group having any problems, but I just spoke in England last Saturday. And I told them, I said, some of you will be absolutely angry you're sitting here for 7 hours. And some of you will just be ambivalent, and some will really be turned on. And I think this group is probably going to be more the latter, the more turned on group. But I'm going to demonstrate to you why, scientifically, The things we're discussing are absolutely true. There's no question about this. In other areas of medicine, orthopedic surgery, in podiatric medicine, in neurosurgery, there is no question about these medullary bone diseases, these osteocavitation lesions. Now, why dentistry has to have a problem with this, I do not know. However, they're the losers, and we're going to forge ahead here. I'm going to show you some reasons why there's no doubt about these things. I'm also going to show you some other things, and finally, I'll show you some actual cases in treatment, and we'll discuss some things, and anytime you have a question, just hold it, write it down, and at the end we'll discuss it. So, may I have the lights, please? We're going to, if you want to sleep, it's okay. It's all right, really. We're just going to talk about it. See, isn't that better? The historical review, real quickly. These are not new entities. These things were described as early as 1794 in the literature in long bones, the tibia, the femur, the fibula. But G.V. Black, as Susan so eloquently stated in 1915, if you're not a dentist, G.V. Black is the fellow credited with bringing dentistry into the modern times. He wrote voluminous amounts of material on how to prepare teeth and how to do this and how to... He was an expert in all areas. The interesting thing is my grandfather knew Dr. Black. My grandfather graduated from Case Western University College of Dentistry in 1922 or 23. And so he knew this fellow, and I actually have G.V. Black's original textbooks, including his pathology book. And so what we're saying here is Black in his textbook on pathology had a chapter on osteomyelitis. Now you understand, many, many years ago, osteomyelitis, and even today, is a killer. Osteomyelitis, as most of our physician friends think about it, is a killer in third worlds. However, G.V. Black wrote a chapter on that kind of osteomyelitis, but this we're talking about is a different kind. And Black called it chronic osteitis. He has a whole section in his textbook on chronic osteitis. And he said there was a bone death, a cell-by-cell death, with the creation of alveolar intramedullary in the bone marrow cavities, which is a problem today. Some of our colleagues don't like the word cavities. Well, tough darts. There's no swelling or elevation in the body temperature. There's no suppuration or pus formation. But this problem of osteocavitation lesions or osteitis has been forgotten over the 20th century, now in the 21st century, because so many times they cover things up with antibiotics or they're quiescent and don't cause pain. That's the thing, like Susan pointed out. They don't cause pain a lot of times, and so people don't realize they have these problems. Thoma, who was a very famous oral surgeon, by the way, I have his 2-volume original text from my grandfather too, in the 30s and 40s, Thoma was likely the first oral surgeon to write specifically that these residual infections or osteitis areas were correlated with old extraction sites. He said that in his textbook. And Thoma is counted on as probably being the quintessential oral surgeon in the 20th century, yet they kind of forget about this in his textbook. Box, who was a British oral surgeon, in 1955 reported a large series of intraosseous cavitations, or he called them vacuolations, in old extraction sites with no production of pus, what we call suppuration, or bony sequestra. If you haven't had pathology, bony sequestra are pieces of dead bone that actually flake off and come out of these areas. Ratner and Roberts are two oral surgeons. Gene Ratner is still in practice in Brooklyn, or the Bronx, excuse me. Ratner wrote an article and Roberts wrote an article independent of each other, but serendipitously were published the same year in the Journal of Oral Surgery, Oral Medicine, and Oral Pathology. This is the Bible in the world in oral surgery. These two men wrote articles which are outstanding classic articles today. It's interesting, Gene Roberts is an interesting man because Dr. Bocaux was called in to nail this guy. Dr. Roberts has been doing these surgeries for many, many years. He kept two samples. One sample he sent off for biopsy, one sample he kept in his office. The Dental Board of West Virginia wanted to say this man was performing unnecessary surgery, so they called in Jerry Bocaux, who was professor of oral pathology at West Virginia University. Jerry looked at the samples. Now, like Mike said, Jerry served a year fellowship at Mayo Clinic in Rochester, Minnesota, and he spent a year under the #1 pathologist in the world in bone pathology. He's the only person we know of in the world who's an oral pathologist who studied bone pathology for an entire year. And Jerry looked at these samples and he said, there's something here I've not seen before. There's something going on, a degenerative nature, an ischemic problem. So Dr. Roberts was vilified first by the dental board in West Virginia, then Jerry vindicated him, and by the way, Jerry lost his job at the university because he stood up for this man. Love it. Liberal people are anything but liberal, by the way. Boco, you can tell by my tie, Jerry Boco then turned in 1995 neuralgia-inducing cavitational osteonecrosis, as Susan said, for painful lesions, because that's what he was dealing with. However, there are many of these that are not painful. Now, there's a current longitudinal study going on at the Maxillofacial Center in West Virginia, of which Michael and I are parts of, and so are the other guys, David and Ray, and over 9,000 samples to date. Nearly 10,000 of these patients have been taken. This is going to be a longitudinal study, perhaps 10 years long. So we'll probably end up with 60 or 70,000 cases. There's no way you can dispute the pathology on that kind of study. When they publish 2 and 3 in a medical journal, call that a study. We'll have 60 or 70 or maybe 100,000 cases. They're called Ratner bone cavities. This is all Susan did this thing. The periodontal literature itself calls it alveolar osteopathosis. Cavitational pathosis, as she said in China. Osteonecrosis, osteomyelitis, inico. But now I'm going to show you something here, especially for the dentist. Our dental profession, the dental boards don't want you calling these things cavities. Well, let me show you what the literature says about these. Look at this, idiopathic bone cavities in the Journal of Oral Surgery. Isn't that something? The conclusion was surgery is the only way to rule out the more aggressive asymptomatic lesions, a la cancer, that idiopathic bone cysts may resemble. The question is this: if you see something wrong on an x-ray and it's asymptomatic, do you leave it there? Well, if you do, 1 out of 472 of these things have a malignant tendency. Do you want to leave it there? I don't. If you're my family, I wouldn't leave it in your mouth. Further in the literature here, again, idiopathic bone cavities of the mandible and oral surgery again. The conclusions are surgical exploration is in order. See, the question here is these oral surgeons say these things don't exist. I just hammered my head against the wall in England last Saturday because oral surgeons over there don't believe these things exist either. Well, I don't care if you don't believe they exist. I don't care. But even the literature, our own literature says these things exist. Look at this, bone cavities, idiopathic bone cavities in oral surgery again. Conclusions: each case was treated surgically and the contents of these cavities were examined histologically. The cause of such bone cavities is obscure. That is not the case today, my friends, but that was 1963. But they were talking about it in 63. And we're arguing about it today in 2002, 40 years later, almost. Incomplete bone healing of experimental cavities in dog mandibles in the British Journal of Oral Surgery. Conclusions: there are 3 factors that influence bone regeneration. The size of the cavity, of course. The removal or not of the cortical plate. That's an issue when we do surgery. And lastly, the elevation of periosteum or not. That's a technical issue you don't have to worry about. The point of the matter is, again, in the literature, back in '71, in dental literature, they discuss these things. Again, observations on 2 types of resorption cavities in the human lamellar cortical plate. Again, clinical orthopedics related to research. Such cavities contribute significantly to cortical porosity and overall cortical bone loss in disease processes. Again, I'm just trying to point out to you this is in the literature. You can't deny it. If they want to live by the literature, they're going to have to die by the literature too. It's in the literature. Alveolar cavitational osteopathosis in the Journal of Periodontology. How can you tell me this doesn't exist? Conclusions: use anesthetic confirmation, like Mike said. Radiographs, look at this, they stay in that article. Radiographs don't define osteopathosis. Surgical removal of the lesion is indicated. And they nail people because they claim we're doing unnecessary surgery. Further things, now in Scandinavian ENT journal, diffuse sclerosing osteomyelitis of the mandible. Chronic sclerosing osteomyelitis in a Scandinavian radiological journal. Further, osteomyelitis of the base of the skull in clinical radiology. Necrotizing external otitis in Louisiana Journal, or the Journal of Louisiana State Medical Society. Facial paralysis due to petrous abscess, that's a temporal bone. The Journal of Laryngology and Otology. These things, my friends, are in the literature. You know, it's kind of funny. I can understand, I don't agree, I can understand them arguing about amalgam. I haven't placed an amalgam since 1979, by the way. But I can understand them arguing that. But I cannot understand this at all. When any other area of medicine, and I'm sure when Mort was practicing podiatry, the issue of medullary bone diseases wasn't even an issue. It was there. You knew it, didn't you? They just argue about this all the time. Further examples, osteomyelitis of the orbital bones in the Journal of Pediatric Ophthalmology. Again, further things. Just go on and on and on. Here is a standard textbook used in 96% of dental schools in North America. There's a section on Nico lesions in this textbook. Now, if we're going to have it in dental schools that are accredited by the American Dental Association, yet we're going to say these things don't exist? Dear Lord. Refereed dental journals. Oral surgery has had articles. These are all refereed scientific journals. Oral surgery has had it in there. Journal of Oral Maxillofacial Surgery, General Dentistry, Craniomandibular Practice, excellent journal, by the way. The Journal of Periodontology, look at that. The Journal of Endodontics has had articles on this thing. Craniomaxillofacial Surgery, Dental Maxillofacial Radiology, the Canadian Dental Association Journal, Dental Clinics in North America. The Dentists in this group know these are reputable, good journals. The British Journal of Oral Surgery, or Oral Maxillofacial Surgery, the Journal of Pathology and Medicine. Look at this. Journal of Prosthetic Dentistry, that is the Bible in dentistry. Look at all these. The Nigerian Dental Journal, by the way, that is a good journal too. The Journal of the Missouri Dental Association, look at this. Now look at this. If that doesn't convince you, look at all the languages that Nico osteocavitational lesions have been published in refereed journals. It doesn't exist, does it? Here's what we're talking about. We're talking about an area in the bone medullary spaces, the bone marrow, where there is some type of ischemic process. Something has caused the bone to die. There are all kinds of reasons, as Susan so well described, all kinds of reasons why, whether it's trauma, whether it's toxicity, whether it's injury, it doesn't matter. Something has caused bone cell death here, and it spreads slowly like a cancer. Now, it's not a cancer, but it spreads like a cancer. And it develops this large lesion, then further on, a secondary lesion or a tertiary lesion can occur. And if a major nerve, like the inferior alveolar nerve, runs through there, it becomes demyelinated, and they begin to experience trigeminal-like symptoms. That's why so many of these patients have the diagnosis of trigeminal neuralgia. On at least 3 occasions, I've operated on patients who were scheduled later that week for intracranial neurosurgery, who did not require it. Now, it's not because I'm some special surgeon. Mike is, but I'm not. It's the point of the matter is it wasn't diagnosed properly. And I'm not picking on neurosurgeons. I hold them in the highest regards. But the thing is they don't understand this. Physicians seem to go past the teeth and the gingiva and want to see the epiglottis and the throat. That's all they want to see. They don't realize this is the barometer of the mouth, or the body, excuse me. Now look at this. Here's the problem. The problems of recognition of these disorders by allopathic physicians. Number one, they're unfamiliar with oral diseases. They are, that's just a fact of life. Number two, they do not realize that the jawbone lesions are of ischemic nature and not a suppurative or a pus-like nature. They're thinking of the third world kind of osteomyelitis, which is acute, which is deadly. This is a different kind of osteomyelitis. They mistakenly believe that all severe oral facial pain is trigeminal neuralgia, which it is not. Symptoms are confused with trigeminal neuralgia, but what a dentist, allopathic dentist, now why don't they recognize these things? Well, they're unfamiliar with oral diseases. They don't recognize that jawbone lesions are of ischemic nature. They mistakenly believe that all severe pain is generally trigeminal neuralgia, and they commit intellectual suicide. I'm telling you, dentists commit intellectual suicide. Is this all I got to know? Is this enough? I remember dental school. Some of us were a little older. Some of us had been in the military, so we came back, and I remember classmates were angry because I'd ask questions in class. They wanted to go out and drink beer and throw frisbees. I kid you not. And I was paying for this education myself. A lot of money, and I wanted to learn as much as I could. And so dentists are that, I don't know about podiatrists, but dentists are that way. Teach me just what I have to know so I can get licensed, I can buy my sailboat, buy my Mercedes. Those are fine. Those are fine. But, you know, quit thinking of yourself as a tooth mechanic and quit committing intellectual suicide. I do not, yeah. If I didn't learn it in school, it can't be true. If you know me for any more than 10 minutes, you'll know I do not like government intervention at all. Keep your hands off of me. That's what the Constitution says. However, one of the very best things that state governments have done is cause dentists to have to take continuing education. These guys weren't doing it. And what they do is they check in, they'd write their name, and they leave and go play golf, and that would be the thing. Well, now they have to wait till the day's over before they get their certificate. That doesn't mean they learn anything, though. Now, your eyes only see what your brain knows. Briefly, dental anatomy, there's a crown, there's a root. The crown is avascular. It's made of enamel. There's no blood supply. How many times have we dentists heard women say, I lose a tooth for every baby I have? The baby, or the worst thing is, oh Lord, the physician says the baby robbed your body of the calcium. That is ridiculous. There's no blood supply to this crown. Anatomically impossible to rob yourself of that calcium from a baby's metabolism. Now there's another way. So the crown is totally non-vascular, aneural. There's no blood supply, no nerves. It's made of crystalline rods, just like glass or ice. That's why it can shear. That's why it shears off. The root is covered with a connective tissue-like material called cementum. This is what's so sensitive when you have gingival or gum recession and you touch the area with your fingernail or a toothbrush, or the hygienist touch your root with an instrument to clean your teeth. The root also, within the root, has dentin. Dentin is the largest material in the tooth. It's more organic than enamel. It's pierced by dentinal tubules, thousands and thousands of them, and the whole tooth is suspended by a periodontal ligament in the socket. The nerve in the tooth is composed of blood vessels, lymphatics, and all kinds of nerves, autonomic and pain fibers primarily. And there's a thing called an apical foramen here, which is the large opening, but that's not the only opening. This is a really neat photograph of the blood supply within the pulp of a tooth. This is called a pulp horn. Look at that. Isn't that amazing? There's so much blood going into that tooth. The problem is when you have a swelling in the bone or in the apices of these teeth, the blood can't get out, and it gets stagnant and kills the tooth. Now, dentin is more organic than enamel. It contains these dentinal tubules, and now listen, within the tubules are things called odontoblasts. They are dentin cells with long protoplasmic extensions, like axons of a nerve. That's exactly what they are, by the way. And they go in these little odontoblastic tubes from the center of the pulp of the tooth out to the surface of the root. So there is a tubular communication from the pulp to the outside of the tooth, a direct communication with the root surface. Now here's a drawing. Here's the pulpal tissue here. Here's the odontoblast, the cell that forms dentin. Then there's also a tubule right here that connects with other tubes and also contains a axonal or a nerve extension through there out to the outside of the tooth. This is an open tube to the outside of the tooth. Here's a drawing of it as well. Here's the pulpal tissue. Here's the dentin. Here's the odontoblast right here. Here are the dentinal tubules right here. Now look at this. We'll come back to this later, but look at the curvature here. See that? There are so many of these things. There are as many in the smallest lower anterior tooth as 22 miles of these things in each tooth. It's a lot. Just a normal structure of a tooth. This is a bicuspid tooth. You can see what the pulp, here's a pulp horn, here's the pulpal tissue, and here's what you commonly call the root canal or the canal for the pulpal tissue. Here's a drawing demonstrating there's more than one nerve supply to this tooth. There's a main nerve along here that brings nerve supply through the apical foramen or foramina into the tooth, but there's also nerve supply in the periodontal ligament and the periosteum and the bone itself, bringing nerve supply directly to the tooth. But with nerve supply, there's also arterial supply as well. Not always venous, but there is arterial. Now, let's talk a little bit about, we'll get to cavitation, but I want to show you something here. In Mort's run, I read an article that he wrote. I read it last night. It was an outstanding article that described this. But the focal theory of infection, this is something that was in vogue in the 1890s through about 1925 or 30. Then it went out of favor, and I'll tell you why in a moment. But Dr. W.D. Miller, who was from Ohio State, by the way, who was a DDS, MS, and a PhD, or DDS, MD, PhD, in 1891 first brought this up, that there has to be something causing disease in the body other than just localized infection, and he felt it was having to do with the oral cavity, the teeth, the gingiva, the bone. William Hunter, who was a physician in 1910, wrote The Role of Sepsis and Anti-Sepsis in Medicine. He said he criticized the saving of dead teeth. This guy was really ahead of his time. He felt that restorations in teeth, now listen to this, Dennis, restorations may be contributing to the death of teeth. That book that Susan held up absolutely describes that. I read that book. I'll tell you what, I'll tell you about it later. Dr. Frank Billings, also a physician, wrote Chronic Focal Infections in the Archives of Internal Medicine in 1912. They felt that a lot of the body's diseases were caused by diseases of the oral cavity. Billings said the focal infection is the most commonly situated in the head, but may be located in other organs or tissue. He said most of the things happen from the head down. Now, Dr. Weston Price. Weston Price was from Cleveland, although he went to the University of Chicago. He worked for the American Dental Association, but at that time it was called the National Dental Association. And the National Dental Association, he was their chief scientist in their area of research. And he had amassed several major researchers below him. One was Mayo, who began Mayo Clinic. And they, for years, as long as 20 or 25 years, did research for the American Dental Association. And Price, in over 25 years, published 25 papers alone dealing with the effects of dead or endodontically treated teeth, which produce diseases in remote areas of the body. Now, here's an interesting thing. Weston Price first told us that sugar and refined flour cause deformities, skeletal deformities, and decay. All of his research has been accepted except this bit about focal theory and about root canal teeth. Isn't that interesting? He was called the finest dentist of his time, and the ADA accepted everything he said except these things about root canals. And by the way, this is funny for me because I taught endodontics at Ohio State for 5 years. Dr. Price in 1923 published a book called Oral and Systemic and Dental Infections in Degenerative Diseases. Now, Price felt that bacterial cells metastasize to other areas of the body just like cancer cells. He assembled a team of 60 researchers. He was the chief scientist for the ADA. That group of doctors, PhDs, MDs, and DDSs, published over 220 scientific papers and 3 major textbooks. This was not a lightweight group of people. They used a scientific method to prove the focal theory of infection did exist, and the caustic effects of dead and endodontically treated teeth is very real. Now, here's his #1 experiment, and Susan alluded to this. Endodontically treated teeth were removed from a patient with a chronic disease. Initially it was arthritis, but he did this with many, many people. He took the tooth, and after cleaning the tooth, in his paper he said he scrubbed it with a disinfectant and cleaned the tooth, then he embedded it in the skin of a rabbit. And every time he did that, within 3 to 12 days, the rabbit would contract the same disease that patient, the human being, had, and oftentimes would die within 14 days. Now, to prove this, if you're into homeopathy, he did it 30 times one time. He took it from one rabbit, the dead rabbit, to the next rabbit 30 times. Every time the rabbit died with the same disease that the human being had from where the tooth was removed. He embedded healthy teeth and sterilized coins in the rabbits as well. And what he demonstrated there was no adverse reaction other than a contact dermatitis. And sometimes a cyst formed around these foreign objects, but the rabbit didn't get sick and die. It's kind of funny, isn't it? His second experiment, he cemented small tubes in the root canals of extracted teeth at the apex, that apical foramen. He pumped water under pressure with dye into the extracted tooth, and look at this. The dye traveled through the dental tubules and entirely through the cementum and was expressed on the outside of the tooth. So he proved there was some type of communication from inside the tooth outwards. That was never known before. And how many of you in dental school have heard that? Not one of us, have we? Well, continuing on, Dr. Ralph Steinman in the 1960s discovered this, and he wrote about the fluid movement through dental tubules. How many of you heard of Ralph Steinman here? That's because you know Huggins, that's why. But Besides that, she demonstrated parasympathetic stimulation produces fluid movement from the pulp outward. Conversely, do you know what happens? Sympathetic stimulation or sugar causes movement from the outside to the inside. Now, how many of you in this room, or how many dentists in this room have seen a patient with some kind of carious lesion or a dead tooth with, let's say a dead tooth with no cavity in the tooth? How many of you found a non-vital tooth and there's no cavity, no rhyme nor reason? Every one of us in here who practice dentistry. This is why right here. Now think about that. If somebody's really upset and stressed, their adrenal cortices are going crazy. Their catecholamines in their bloodstream are going nuts. Epinephrine, norepinephrine, cortisol. Those are causing the sympathetic nervous system to be exquisitely stimulated. And what happens when that happens is the flow goes from the outside to the inside. Now, they got a periodontal infection. They got trauma. They've got something that's occurred in the gingiva perhaps. It's going to carry the bacteria from the outside into that tooth, and it's going to kill that tooth. Or there's something going on like trauma from occlusion or a new dental restoration in that tooth, and so the pulp is already inflamed. You bring more fluid into that tooth, you actually strangle that tooth. You see what I mean? Did we hear that in pathology in dental school? We didn't. My friends, it's out there since 1960. Being a teacher, I shouldn't say this, but those who know do, and those who do not teach. They taught the same thing they were taught. Disruption of fluid movement or fluid movement from the outside to the pulp produces pulpopathosis. That is documented by Steinman in numerous studies he did. Now, endodontics and the focal theory of infection. In theory, endodontic therapy is the removal of pulpal tissues, cleansing the pulp chamber, and obturation or filling of the pulp chamber with a supposedly inert material. That's the definition of endodontics. Well, one of them. Dentistry brags that we used to tell the students 95% success rate with endodontics. But you know what? We never told them how long that was successful for. Now let me ask you a question. Let's just be honest in this room. This is the come to Jesus time right now. How many, even for you, Mike, how many of you dentists in this room have done endodontic? We've all done endodontic therapy, haven't we? Come on, who cried when old Yeller died? Who cried? Okay. We've all done this. How many of us have had people's teeth go bad after good endodontic therapy for no known reason? Within even a year or two. Now, would you call that 95% success rate? I wouldn't. We told our students that. You know why? Because the people who I was teaching with told me that. And by the way, the people at Ohio State in the endodontic department are outstanding researchers. They're good people. It's probably the nicest department to work in. I don't know about your dental schools, but I hear routinely that endodontics is one of the nicest departments to work in. These guys were great. Endodontics is the only specialty, thank you Susan and Michael for stealing my thunder, that uses dead body parts. Nobody else uses dead body parts. Name me one other area. Nobody does. So why would we think that root canals should be saved, teeth should be saved? Endodontic therapy began to flourish at the beginning of the 30s due to x-rays. That's a big thing back then. When my grandfather went to school, that was just coming out. By the way, when he went to dental school, did you realize that local anesthesia was not used in the United States for routine dentistry until 1919? A British dentist named Fisher came to the U.S. and traveled the U.S. and lectured to dentists. They used it for surgery. The reason was they still remembered cocaine. Cocaine was used till 1905. People died of cocaine. That's when they put epinephrine in it, and also then they got procaine or novocaine, new cocaine. So they were, back when my grandfather went to dental school, at least his professors still remembered people dying in a dental chair with cocaine injections. So endo thrived with radiographs. Also antibiotics became on the market here. By the way, colloidal silver was used before that time. Colloidal silver is an outstanding antibiotic. There are probably 500 to 600 diseases it will stop. But it came out of vogue too because it was scientific to use antibiotics. Just like in the 50s, it was scientific not to breastfeed your child, right? Those of us who came in the 50s, probably none of us were breastfed. Most of us were bottle fed because it wasn't scientific to breastfeed a child. Well, it wasn't scientific to use colloidal silver because antibiotics were on the scene. Improved the endodontic techniques were improved at that time. The formation of the American Association of Endodontists occurred, and I got to tell you, financial gain. Now, I don't know an endodontist in my life who is purposely trying to hurt people, or a dentist, really. Endodontics is the most lucrative specialty in dentistry, far more than oral surgery or orthodontics, believe it or not. And I'm not faulting those people. I don't care how much money somebody makes if they earn it honestly. And I'm not saying our endodontic colleagues are dishonest. I'm not saying that. But the point of the matter is you've got to consider, if you took a 2 or 3 year residency in endodontics, then somebody's telling you what I'm telling you, you have to think twice about this. The focal theory was abandoned due to the discovery of antibiotics. So when we were in dental school, when Mike was in dental school, and I bet when Roy, when you're in medical school, they said it doesn't exist. Can't exist. That's just old bunk from the last century. Well, does it occur today? Well, listen to this, my friends. Prophylactic antibiotic prescriptions are demanded of dentists before endodental treatment, including just cleaning your teeth, for joint replacements, mitral valve prolapse, especially for regurgitation. If we would do that, if we would do any procedure without antibiotically, prophylactically treating somebody first, that is negligence and malpractice. Veterinary doctors, without a doubt, assume the focal theory is in effect. I was in my vet's office. I love dogs. I had as many as 10 dogs recently. And I love dogs. I was in my office one day with my vet, and Mark walked in the room and said, they had these really stupid looking, I love vets, and they're smart people, but they got to get a better artist. Their pictures are so dumb looking. They got these cats and dogs, and they got a little arrow from the tooth down to the gallbladder, and a little arrow from the gum down to the liver or something. And I said, Mark, do you really believe that stuff about the focal theory? And you know what he said to me? He says, don't you human doctors believe that? Touché. If no focal theory of infection, why prophylactic antibiotic recommendations by the American Heart Association and joint replacement surgeons? I mean, that should end the discussion right there. If there's no focal theory, then I'm going to treat you with a new knee and a mitral valve replacement, mitral valve replacement without antibiotics. They would take my license and sue me immediately for that. Does it make sense? Without antibiotic coverage in these patients, it's considered below the standard of care and negligence. You got to have it one way or the other. You can't have it both ways. There either is or isn't. Now, in the medical literature itself, today, this is not in the 19th century, this is today. Areas of focal theory of infections from the mouth have been noted in the head, in fascial planes throughout the head and neck regions, eyes, brain abscesses, in the meninges, in the neck, or in the spinal cord and brain, in the lungs and the cardiovascular system, the GI, low birth weight, and infertility. Doesn't exist, does it? But they have. This is documented by scientific papers. Now, look at this in scientific articles. Periodontal disease and the risk of fatal coronary heart and cerebral vascular diseases in the Journal of Cardiovascular Risk, talking about periodontal disease causing this. But it doesn't exist, does it? Dental infections as a risk factor for acute myocardial infarction in the European Heart Journal, but it doesn't exist, does it? Focal infection in the Journal of Dental Research. This is a very well-known and respected journal, but it doesn't exist. Well, how about this one? Total knee arthroplasty infections associated with dental procedures in the British Journal of Bone Joint Surgery. Doesn't exist, does it? Dental plaque, platelets, and cardiovascular diseases in the Annals of Periodontology in our own journal. Doesn't exist, does it? Cardiovascular infections, bacterial endocarditis of oral origin in the Journal of Clinical Periodontology. Doesn't exist, though. Then why do they do this? Toxic shock syndrome secondary to dental abscesses in the International Journal of Oral and Maxillofacial Surgery. But it doesn't exist. I mean, do you see how stupid do you see why I said that dentists commit intellectual suicide? I'm reminded, and I'm not going to preach to you here, but I'm reminded in Romans chapter 1, verse 22, it says, professing themselves wise, they become fools. End discussion. Effects of oral flora on the platelets, possible consequences in cardiovascular disease, the Journal of Periodontology. Periodontal disease is a risk factor for heart disease. That's compendium of dental continuing education, by the way. And if you don't believe that, just read USA Today. They got articles all the time on this stuff. Brain abscesses following dental infection, oral surgery. Dental infections associated with cerebral infarction in young and middle-aged men. Journal of Internal Medicine. Now, what's the problem with dead teeth? Well, there are miles and miles of dental tubules. These things contain protoplasm. My friends, if you don't get nourishment, what happens? It dies, it rots. It has autolytic necrosis. It can't get out. Like I said, in the small little anterior teeth, you have as many as 22 miles of these tubes in one tooth. Can't clean or disinfect the dental tubules regardless of the techniques used. Conventional endodontics with gutta-percha fill that we were taught. Sargenti endodontics, that uses formaldehyde to pickle everything. Biocalyx, I'm sorry, I'm not against my friends who use biocalyx, but you cannot clean dental tubules. That's where the problem is. Laser and biocalyx. Remember I showed you those dental tubes, how they curved? Unless those things are made of lucite, you're not going to get light to go around those curves. Right? That's the only way. Look at this. Look at these curves. How are you going to blast this thing with a laser? Look at this. If it's straight, yes. See, all the drawings you see, they're straight. This is an actual sagittal slide of a tooth. Now, by the way, look at all the accessory foramina going out of this tooth here. You can clean this out, like Mike said, real well. There's no doubt about that, is there, Mike? No. But look at this. What are you going to do here? Oh, we'll do an apicoectomy. So we cut it off right here. But did I get that up there? No. Look at this. Look at the accessory foramina here. Look at this. Look at this. Now look how this curves. These tubes are going up like this. Look at this. You're going to tell me you're going to put a laser through there? The Lord didn't give us lucite tubules. You can't do it. Look at this. Look at this in the furcation. That's the accessory canal. You're not going to fill that. Look right here. And look right here then. How safe is dentistry really? This makes you want to drive a truck. Absolutely. Somebody at the table at lunch said, what's safer, a dental office or a hospital? Dear Lord, they're both going to kill you. Look at this. Dr. William Hunter felt dental restorations caused pulpal death. Well, what did he know? He's an MD. What does he know? You know, that's 1890. What does this guy know? I'm being facetious, of course. Dental tubules contain odontoblastic processes, or axons. All these tubes have an axonal process within them, a nerve. Dental cavities and dental procedures can damage these odontoblastic processes. Cumulative damage may produce pulpal degeneration, thus pulpal death. Also, the big thing today is composite restorations. So what's one thing you've got to do with composite? It fails because it gets wet. So you dry the snot out of this thing. You desiccate the pulp. And when you blow air on this pulp, what happens is the tissue contents of this tube are extruded outwards. You dry out and damage, and you can kill these nerves. How many times do you know, or have you had a very sensitive tooth after having a composite restoration? That's one of the biggest problems a dentist has who places composites. The patients routinely come back with sensitive teeth. And a lot of us have seen teeth die more than they did with amalgam, by the way, with composite restorations. Do you agree with that? True. A lot more teeth die with this. So we should be putting amalgams back in, shouldn't we? Here's a problem, my friends. Can I have the light again? Just turn the light up first. I want to show you something. I could just use Mike's drawing here, too. Here's what you've got. You've got several dental tubules like this. I'll just write them like this. Can you see it back there? Okay. And you have to understand, he put a crown in this tooth, but they're going up like this. The dental tubules are going like this. Okay. Now, here's the problem. If you shear off a piece of tooth, or you have a cavity between the teeth, it may take out a section of tooth like this. It may take out a section of tooth like this. Okay. So what you've done is, let's just say you've damaged X number of dental tubules, okay? However, when the dentist restores that, he or she comes in here and they have to cut down this tooth here. They cut this tooth down like this. They cut it across here like this, and they make a crown, and so they damage X plus all the rest of these tubules. Now, if they damage enough, it's going to die. Now, there is a thing in pathology. Do you remember what Wallerian degeneration is? Wallerian degeneration is a state of degeneration in a ganglion, a complex or a cluster of cells, that if you cut enough of the cell processes going to that cluster of cells, the cluster of cells dies, right? Basically, right, Roy? Basically. That's why I think people who are 50 years of age and older are more commonly affected with true trigeminal neuralgia. Because at that age, they've had more trauma, more root canals, and more extractions, more periodontal surgery, more crowns than a kid who's 25 or 30. So what happens here is you cut up enough of these dental tubules, you can kill this tooth when you've done the nicest dentistry in the world. It's not the dentist's fault. It's the fault of the anatomy of the tooth. We were never created to have rotten teeth. Go back to Weston Price. Listen, I want to go to Dairy Queen. If you guys want to, margaritas are full of sugar. I love margaritas. The problem is if you're not healthy, and if your autonomic nervous system doesn't work right, you're going to get dental disease, periodontal and tooth disease. And the dentist is going to have to do something for you, or else you're going to have abscesses and dead teeth and periodontal disease. That is a very simple overview of this thing. But does it make sense to you? That now why we cut more and more of these dental tubules, so we make a small filling when they're 16 years old, they're okay. But at 25, they break the cusp off, so we put a larger filling in there. We as dentists know it as an MOD, three-surface big restoration. Amalgam or composite, it doesn't matter. Then what happens is they're 35 or 40 and they fracture the tooth again, they have to have a crown. So now that tooth's been nailed at 16, at 25, and now at 40, and those teeth are starting to die. And what do we commonly see on an x-ray, by the way? We see sclerotic dentin formation, or sclerotic bone formation down here. The tooth is screaming, I am in trouble. Help me, I'm in trouble. The tooth is dying. Yeah, but these things don't exist. Lights, please. Making sense to you so far? Yeah. Is anybody awake out there? Okay. Yeah. What do I do with my... Now I'm looking for... Oh, there it is. Oh, I want to back up there. Delete? Oh, Lord. Okay. Here's our problem, my friends. It doesn't matter if you get slammed in the face playing hockey, or you have a tooth break, or you have a cavity. You have an initial clinical insult to the crown, causes pulpal inflammation, increased pulpal pressure. Your tooth becomes a contained hemorrhoid. That's exactly what it is. You have venous collapse. It's incredible what happens in this thing. Veins collapse, there's stasis of blood, ischemia. You can't get oxygen in there. You can't get metabolites out because it's so swollen that at those exits of the teeth, the foramina, you can't get out because it's so swollen there, like a hemorrhoid. You have local necrosis. You have all kinds of intercellular mediators of inflammation released. Then you get a circumferential around the tooth vascular disturbance, those other blood vessels I showed you. You have an increase in tissue pressure, and the whole thing dies. And when it dies, the bone around it dies as well. It's a complex cascade of events, which it may stop here if you take an NSAID, for example, an anti-inflammatory, or something to stop the inflammation. But if you don't do that and it goes on, you got a problem. So you get enough of these axons damaged, you come up here and you kill the cell bodies in the trigeminal or Gasserian ganglion. And what happens is a portion of that ganglion starts to die. And when that happens, this ganglion dying, it comes into the central nervous system. We won't go into the neuroanatomy as much as you want me to do, I won't, in the neuroanatomy here. But it actually goes from here, crosses the midline generally, goes to the thalamus, then goes to the somatosensory cortex. You feel pain. It's constant pain no matter what you do. You take the tooth out, the problem is still there because the bone is damaged and there's enough axons in the ganglion here that still produce pain as a generator. We've got to get on these things right away. The longer you let them go, the more trouble it is. Now, types of osteocavitation lesions, there are at least 14 or 15 kinds, but the more common, the NICO, and within NICO you could probably call ischemic osteonecrosis, regional ischemic osteoporosis, chronic non-suppurative osteomyelitis. These generally produce pain. This focal osteoporotic marrow defect, that's bone marrow edema. That's the one, if you can catch it when it first occurs, you can stop it. But you never know because this rarely causes pain. Condensing osteitis, that's when the tooth is screaming, I'm dying, I'm dying. You see it on the x-ray. A bone scar, that's the result of condensing osteitis. And then you get traumatic bone cysts from bleeding in the bone. Now, I'll show a few. Thanks to Susan, I'm not going to go through a lot of this. I really mean this. Susan's been a great contributor to our knowledge of this. But you got to get this book, my friends. The best book out there. And I've written a book. This is the best book out there. I would say give this to your patients. I don't know what it costs. It doesn't matter. I'd buy the book and just charge your patients. Let's say if it costs $20, charge them $20 more and give them the book. Seriously. Or sell them the book. But that's what I do. And they love it. They love to get something. But boy, what a wealth of information you got. It's the best book out there. Suffice this, I'm not going to go through all this. Extractions. Anybody in this room who's done an extraction or who's been the recipient of an extraction know what a brutal operation that can be. Even the finest dentist can cause bone death and bone marrow damage because it's a terrible thing to have an extraction sometimes. Recontouring a bone or cutting a bone. Man, you better get people wet. They're soaking wet when I'm done with surgery. I bet they are in your office too, aren't they? Yep. Failure to remove the periodontal ligament. You already had that. Here's one that wasn't mentioned, I don't think. Poor tissue retraction for the doctors in here. If you retract tissue poorly, you cut off blood supply, you damage periosteal arteries, you kill bone. Injury, okay. You've seen all this stuff. I'm going to go through this here. I just can't go faster. Periodontal disease, okay. I'm like Mike now. I'm like the... Oh, got to do this one. Dentist, if you're using vasoconstrictors, cease and desist immediately. You got to stop. Here's a big one right here. There have been look what this came from too, my friends. Look at this. Pathways of the pulp. That's used in all endodontic residencies. They tell them in that book, don't use vasoconstrictors, and they use vasoconstrictors. We in dentistry use vasoconstrictors, if you're not a dentist, to cut down blood supply, to cut down bleeding during surgery, and also so we can keep the anesthetic in place longer. We learned to do that. Every one of us learned to do that. That was standard operating procedure. The problem is, Kim and Trowbridge have demonstrated that there's a pulpal reaction, and so is Bernard here. Look at this. If you use an infiltration injection around a canine tooth, you can cut the blood off for as long as 60 minutes in a canine. If you cut the blood off, guess what? You're cutting the oxygen off. Now, what on this earth can live that's aerobic for 60 minutes without oxygen? So let's say we cut the blood off for 60 minutes, and that tooth has had a large filling in it. Guess what? We've damaged axonal processes here. We're going to kill that tooth. Here's one that shows if you infiltrate around canines, 75 minutes of oxygen deprivation with vasoconstrictors. My point is, don't use vasoconstrictors. Here's the problem. Coagulation risk factors. Susan went through those. All these things are genetic things that you and I have. We have genetic things to help us oppose these. You are right now forming thousands of blood clots as you sit, especially in your butt and your legs right now. But you've got things the Lord has given us to break those blood clots up. The problem is, if you have a genetic predisposition, you can't have a genetic factor to make this backfire, and you start to form blood clots. Well, generally they're metabolized, they're eaten up by the body. But if you add a vasoconstrictor, if you have trauma, if you have a dental abscess or a large insult to a jawbone, you slow the blood vessels down, or the blood down so much, and you have a risk factor here, you got a blood clot, you've got a heart attack of the jaw. Steroids are wonderful if you want to feel like you're high for a week and want to get your inflammation stopped, but they cause vasoconstriction, swelling the blood vessels. Birth control pills, these are the two big ones in females, and birth control pills do the same thing. Heavy smoking also, as Susan said, does the same thing, and alcoholism. These are big ones right here. Now, in the surgeries I do, those that are failures, about 75% are these problems here. Now, Michael, what I'm doing now is every person before I send, they have to get a certain, I'll send it to you, a certain blood screening. They have to get that, or I won't see them. And I've already, in the last week, fended out 2 patients who had genetic problems before I even saw them.
What do you do with people who are smokers, other than show them the door?
Talk to them a lot. Talk to them a lot. I'll tell you about that later. I don't have as much trouble with smokers as the literature says, but I scare the bejesus out of them too. Here's the problem. You have intravascular coagulation activated by a variety of underlying disease conditions. a probable common pathway producing intravascular thrombi or blood clots and marrow space pressure, edema, compromised blood flow, pressure in the marrow spaces, thrombus and or ischemia. Pressure, blood clots, dead bone marrow. Compromised blood flow, you got a thrombus formation or bone marrow edema, or you could have both. Then what happens is you have ischemia, lack of oxygen, and that brings marrow death. That's what happens. I don't know where Susan got her statistics, and I don't doubt them, Susan, because you're always on top of things, so mine are wrong, yours aren't. Suffice it to say, though, that now epidemiologically today, we know that hips and jaws have about the same frequency in the general population of ischemic osteonecrosis. Then knees are third. Men have far less than women. She said 75% women. She's not totally wrong, and my studies have demonstrated it's 71% women and 29% men, so close enough. Close enough. Look at this, the rule of 80. Approximately 80% of sufferers are women, 80% are 30 to 55 years of age, 80% have a prothrombic tendency, they form blood clots, 80% experience atypical facial pain. 80% have tender spots over the area, and about 80% have elevated body temperatures. Now, the symptoms of these Nico lesions: history of undiagnosed facial pain, a dull, constant aching with sharp electrical pains. No wonder our physician colleagues and oral surgeon colleagues and dental colleagues think this is a trigeminal neuralgia problem. They may be totally painless, however. Now listen, this is a big one. Do you see this, Michael? Do you see this, David? Sour taste is a big thing. If they say, I've got this problem, I say, do you have a bad taste? They go, yeah. My wife says my breath stinks, or I got a bad taste, or my stomach bothers me. Sour taste is a big one because there's a common drainage out of the bone into the mouth of this fetid, rotting, decaying bone marrow. Did I make my point there? Yeah. Pressure at times. They'll have pressure when they lie down, pressure when they bend over, pressure when they exert themselves. At times. They have a history. Now here's the big one. A large restoration, the 16-year-old. Chronic sensitive tooth, the 25-year-old, so they get it filled again. Endodontic therapy because it hurts so bad. Multiple root canals on the same tooth. We got to do it again. Oh, I had one lady had it done 6 times.
Did they get it right?
Never, never. Then they do an apigoectomy. That's an amputation of the root because the root canal didn't work. I mean, come on, friends. Then they finally extract the tooth. Can you believe that? That's what they're doing. They have trigger areas in the mouth that can be triggering, causing the problem. Normal radiographic findings initially. Generalized fatigue, GI upset and burning on their stomach, nausea, diarrhea. There is a classic referred pain pattern of these Nico lesions. Bless you. Here's what I'm talking about. Sour taste, fatigue, stomach bothers them, fetid breath. Right here's what you got. I took away the gingiva, and look what I found immediately. It was a hole. I love to see these folks come in my office because I see them, and I bet you do too, and you do too. You see, and they tell me, you can see the spots right here. If you look real close, you generally can see, if they complain of sour taste, generally can see a little red spot. So I find a patient who says, I have pressure, I have a bad taste. If you look in the mouth closely, you can see a little red spot, and you can actually insert an instrument and go right down the bone. It's wonderful. Here's that famous picture that Susan showed too. This is what it would look like underneath that hole. Here's that case. Now look at this. This lady who committed suicide, if you see this, there is called a fenestration. There's a hole in the bone where this tooth is. By the way, Susan didn't know this. This is an endodontically treated tooth. Look at that. Look at all this. That's the same side right here. Look at this. When I cut the buccal plate off here, this just oozed out of here. Just ran out. Here's the nerve right here. Here's another shot. Here's the infraalveolar nerve. Look at this bone marrow all dead all around this nerve. If we operated, we'd have to move that nerve and make a new channel. Look at this. Look at this. Here's the nerve. Here's the mental nerve. Here's the infraalveolar nerve and artery. Look at all these areas here. It's incredible, isn't it? Look at that. Now, Jerry Boco and I are going to further do a study on this. And if I ever get a moment, I'm going down to West Virginia. We're going to further section these things and write a paper on this. But I've just been too busy. That's what we're dealing with again. Now, diagnostic tests. Again, Susan, you sold my thunder, but you did a good job. Panoramic x-rays, periapical x-rays, I almost never use those anymore. Anesthetic blockade I use. Bone scan is marginally successful in the mouth, in the face, because it's so inaccurate. If periodontal disease, any kind of healing, any kind of inflammation will make the isotopes be taken up. However, I've got a new one here for you, Michael, in a second. Coronal tomograms, I don't even use those anymore. Electrodermal screening, every chiropractor who sends me patients that use electrodermal screening is totally correct. This is a very accurate test. However, it doesn't show you the extent. It shows you something's there, it doesn't show you the extent. Finally, the cavitat. I would never practice again if you took my cavitat. Never. Now, here's a case right here. Here's a guy, this is George O'Day. Look at this. Looks nuts. The dentist in this room, this looks normal. But those are cavitations right there. Dentist, look at this. We were told in radiology this was okay. They're not hurting, so it's okay. That's not okay. The periodontal ligament is in there. It can't heal. This is not okay. This is years ago. Look at this. But look at all the cavitations in this thing. Here, 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 and here. And yet, any dentist in this room would look at that and say, that looks pretty good. Oh, that might be a little problem, but if it doesn't hurt them, leave it alone. These are all cavitations. Look at this. Now listen, you don't have to be a dentist to see that. That's cavitation. Look here. Now come on, folks. You don't have to be a PhD to see this. Look at this. Look how big that thing is. Maxillary tuberosities are not supposed to be hollow. It's hollow. Now, anesthetic block, no vasoconstrictor, expect incomplete anesthesia when you do these things. And there are several different types of anesthesia responses. A normal one, full terminus, blocking if there's a lesion right there. Sometimes you can have all numbing here, and a spot right there where the lesion is, it doesn't get numb. And sometimes it actually diverts it up to the other jaw. Here's a bone scan. Let me show you something. Now look at this. I can tell you right now because I can read these, and I know this guy right there is a lesion. But you can't tell, is this all lesion? Is that a lesion? Is that, see, they're so inaccurate. But Michael, look at this. I talked to a neuroradiologist in Chicago who told me this. He read one of my papers and gave me a call. He said if you had the patient have the normal bone scan of Tech 99, then return the next day without doing anything else and rescan them, he says if you've got an osteomyelitic lesion, it'll absolutely scream at you on the film.
So did you do it?
I haven't done it yet. This is just about a month ago. Look at this. Here's a case right here. Look at this. This is a pretty good root canal, to be honest with you. Look at that. But look at this. That's how big the lesion was. Here she is right here. Look at this. Now you're starting to see, this is fuzzy stuff here. This is sclerotic bone formation. That's what the lesion looked like right there.
Wes, point out the horizontal lines between the roots on the 19. That is a dead giveaway.
Yeah, exactly. Yeah. Look at this. Look at these.
They're horizontal in nature.
See? And in the mandible, like Mike, that's a great point, Mike, thanks. In the mandible, it's always a vertical because it's in the lines of force. Look at this. It's a dead giveaway. Here's a cavitat scan. Green is good blood perfusion, good blood flow. Red means there's no blood flow. Like Susan said, it's dry or it's a lack of blood flow. Oranges and yellows are transitions. This is this lady right here. Look at this. I mean, again, my friends, do you have to be a rocket scientist to see that? Now, the FDA study that Mike and I participated in, I still think you should have lectured instead of me, by the way. But anyway, no, I'm serious. You did far more than I did for this. But we helped get that thing by the FDA.
That's the whole point. We work as a team.
Absolutely. I might be a little better looking and younger than you, but still we worked as a team. Okay, yeah. If you're using the cavitat, the FDA said this is the recognized diagnostic instrument for intramedullary diseases of the jaws in conjunction with panoramic radiographs. So don't let anybody tell you you can just use a cavitat. You've got to use a Panorex. Here's a study, 3 different studies that were done. Boco, myself, and Byron, who was one of Jerry Boco's grad students getting his master's degree in endodontics. 3 different studies, 3 different populations, 3 different numbers. But look at this. The slopes of these lines and frequencies are all the same. Look at this. Wherever the location of cavitats or cavitations in the maxilla are the same, the mandible, all the same. 3 different studies, 3 different times. Look at the distribution of study I did last year. Wisdom teeth, wisdom teeth, wisdom teeth. Now, here's a study that Susan spoke about. Jerry Bocaux did this study years ago. He said 48% on the mandible, 51 on the maxilla. Look what I say, 48, 52. Same thing. Treatment, surgery. Can I say that again? Surgery. One more time, surgery. Dead is dead. Oh, dead is dead. You got to do surgery. Ischemia and disrupted blood flow demands surgical intervention. Listen, if your gallbladder dies, what do? Well, we're going to root canal the gallbladder? You've got to take it out. I'm being facetious, of course. Mort, you guys didn't try to fix toenails when they had all kinds of problems. You took them off, didn't you? Yeah. You couldn't fix them. You had to take them off. Now, a little different problem with blood flow there, but I understand. But the nail bed itself. You must reestablish adequate blood flow. Conservative manage. Injections of medications and remedies may work only if the condition is detected early. Bone marrow edema. The problem is you can't feel bone marrow edema. So all these remedies people are sticking in there are prolonging and damaging the problem. In their attempt to help somebody non-surgically, they're making the problem worse. And I got no vested disinterest in these companies. I don't. Some of the people who sell those things are good friends of mine. I'm just saying you can't do it, and I'll fight them to the death about this. No blood flow out, you can't remove the metabolites. This may actually prolong and worsen the problem. Now, the use of infrared is promising if the problem is detected early. And I don't have time to go into chemistry on that, but trust me, infrared, the anodyne unit, for example. Infrared, possible treatment, L-arginine stimulates nitric oxide formation. So does infrared. That's the point. That's the crux of the problem, lack of nitric oxide. Ginkgo biloba. It's not spelled misspelled, isn't it? We corrected that, didn't we? It's B-I. She's like my mom. She always gets me I don't spell right. Seriously. This is supposed to be an LT. I prescribe this now because it's got therapeutic doses of vitamin B6, 12, and folic acid. We're talking about antiplatelet aggregation, lowering homocysteine levels, and stimulating nitric oxide synthase. Zinc gluconate's an outstanding coenzyme. Vitamin C, do I have to say anything more? It's a great scavenger, antioxidant, and it's an invaluable coenzyme in the repair of connective tissue. Increased water consumption. Americans are sorely dehydrated. They've got to get more water. I don't mean from Coca-Cola or Diet Pepsi either. Now, diseases. Focal marrow defect, it's bone marrow edema, chronic non-suppurative osteomyelitis, regional ischemic osteoporosis, and osteoporosis. This bone marrow edema is probably the mildest form of ischemic bone disease. There's often no known cause, and there are areas of ischemic damage which are possibly caused by some type of an infarction. Chronic non-suppurative osteomyelitis can be acute or chronic. Most cases arise from tooth infections or trauma to the mandible. There's pressure in the bone marrow. Regional ischemic osteoporosis is not the same as what you get in the back, ladies. It's a different disease process. It's a condition of ischemia within the marrow space, not the cortical plate like you get in the back. It develops fibrous, little wispy fibers in the bone. You can see it on the x-ray. Bone marrow edema develops. And ischemic osteonecrosis, due to a thrombus, there's infarction and dead bone. Now, a study we did that's going to be published this year, 400 consecutive surgeries, 70% were female, 29% men. The average age was 50.6. We had 14 different diagnoses. But here's the point of the study. Out of 400 cases, 330 or 75% were due to some type of ischemia. I didn't go out and pick these. These were absolutely consecutive cases. You're in this, Roy. Consecutive cases. I didn't know this until I did the stats. Half of them were on the one side, half on the other. I couldn't believe it. Look where the locations were. Central and lateral incisors, the cuspids in the maxilla, the first premolar, a sum, but the second premolar through the wisdom teeth, 41% in the maxilla. The same in the mandible, 41%. All of them in the back teeth. Yes, sir?
Do you see more of this in diabetics?
Yeah, absolutely. And you know why, being a physician. Absolutely, microvascular problems, yeah, absolutely. The fragility of the capillary beds and everything. Oh, yeah. And the swelling of the endothelial linings. Absolutely. That's a great question. Diagnoses, the most chronic was chronic ischemic osteonecrosis and chronic non-suppurative osteomyelitis, ischemic osteonecrosis. Now, let's do some stuff. Let's get easy now, friends. Joyce was a 45-year-old single Caucasian female from Long Island. She'd been suffering with extreme fatigue, depression, and recently had a root canal treated tooth removed. She complained of a sour taste and mild right maxillary pain and mandibular pain. Her chief complaint was, see if I have cavitations. Here's her x-ray. Duh. Now you didn't see, you saw the bottom one there. Look at this up here too though. Look at this. Look at this. This whole section just on the maxilla alone. Yeah, just about. You know what I did? Who asked that question? What you have to do is selectively section these teeth. You know what would happen if I tried to take that out. I got the whole maxilla in my hand. So you know what I did? I got a sinus perforation, which this is a given here, but I had no trouble with rupturing or fracturing everything off. Look at this cavitat scan, Mike. Look at this. That means this thing is deader than a doornail. There's nothing. There's no blood flow in here. None. This is dead bone. Took that tooth out. I'm right in the maxillary. That's right in the sinus. It's like, hello there. This is the maxillary sinus waving at you.
You got the echo.
Huh?
The echo comes back.
Yeah. Yes, sir.
How often do they culture positive?
You know what? Okay, I'll answer you right now. How often do your cultures positive? Obviously, in the maxillary sinus, it's going to be more positive than any place else. But overall, I culture every surgical case now. I didn't tell you that either. Every case I culture now. And I've been culturing every case since probably December the 1st. I have had 3 cases come back that required specific antibiotic intervention after surgery. Very nonspecific, very mild growth or no growth on the auger plates. Can you believe that? So, very often. Now, and 2 of the 3 have been from the maxillary sinus. This is not a disease of bacterial infiltration generally.
Do you think that's maybe one of the reasons that the more conservative dentists are having trouble understanding it because they don't see it? That's the question I have. On top of that, maybe we'll talk about it later, but to see what kind of immune indices they have before and after drainage, to see what kind of immune dysregulation you did it certainly without.
Yeah. Well, first, I don't think they're intelligent enough to ask that question. But secondarily, I think you're right. Yeah, if there was a raging infection, and you have to understand too, as anybody, any kind of doctor in this room, regardless of your degree, you know, you have to have a 35 to 40% change in bone before you see it on an x-ray. So some of these have been limping on, and in the bone marrow, again, I love to talk about anatomy. We haven't got time to talk about bone marrow, although I know you want me to, but we don't have time. But bone marrow is like a connection of valleys and hills and little partitions through the bone. And I think what's happening is you're getting some bone marrow edema and bone death, and instead of spreading out and damaging the cortical plates, it takes the path of least resistance and goes a long way through the bone, whether it's the femur or the mandible. Because basically the mandible and femur are the same bones anatomically, the way they're innervated and the way the blood supply is to them, and the way the bone marrow is. So I think it's because on x-ray already, this looks kind of radiolucent, and so when you start to get a spread of this osteomyelitis and bone destruction, it doesn't look that abnormal to these guys. That's a good question. Yes, sir? What now? Oh, that's a great question. I do not place any. I never have, and I never will. The only synthetic things I'll place in here is a membrane to close the sinus if necessary. The guys who study with me know I close every surgery. They don't walk out of my office without being closed. But to answer your question, is if we get it right, if we get the bone to heal, if we get the blood supply and the angiogenesis to occur and the fibroblasts to come in, and now we start to get blood forming again, this will fill in with bone. I saw your eyes. I've been doing this since 1986. Yes, sir.
And I'll also put osteograft material in there called osteograft between 2 membranes and find good healing and good bone regeneration afterwards also. So
Now, sometimes, Mike, if I have a problem with bleeding, I put a collagen plug in there, Colostat. You know. Yeah. What were you going to ask?
Yeah, I was going to ask you a question. Say, for example, you're closing the surgical site. You want to get
Right.
primary closure.
Yeah.
Well, sometimes you have to remove more bone.
Yeah.
To get that.
Take my course. Ask David. I'm being facetious. I do a lot of undermining of flaps and a lot of bony recontouring, but I close everything. And I've done over 1,000 surgeries, and I've had, to my knowledge now, people like Mike, they come to me from all over the world and all the United States. And so, in our business, like Mort or Roy, if you don't hear back from patients, you assume they're doing better. So, in all those surgeries, I can think of 4 dry sockets or alveolar osteitis I've had. That's not bad.
That mandible there, the little white lines around it, you have to go down to the vascular line.
Oh yeah, I'll show you some of that. Yes, Kerrie?
Typically, how long does it take to heal?
Well, I make them keep the sutures in for 14 days. You'll be,
And then the bones?
probably 6 months. The diagnosis was regional ischemic osteoporosis and an abscess. Sherry was a 44-year-old Caucasian married medical records clerk from southwestern Ohio. Teeth numbers 18 and 19 were treated endodontically, but the pain persisted. Imagine that. So she had a complaint of a sour taste, drainage, upset stomach, generalized fatigue. She said, my left jaw hurts, I've got swelling, infection, sour taste, upset stomach, and I have diarrhea. She had a positive history. She took birth control pills. She was a heavy smoker. Panoramic x-ray showed some things. Total relief of pain with an anesthetic block. Here's what it looks like. There are the lesions right there. And Susan's already shown this case. That's what I saw when I opened her up. I reflected tissues and took off a little bit of cortical plate, and that's exactly what I found. I didn't do that. Diagnosis, chronic fibrosing osteomyelitis. Now, I learned a lot from this lady. I had to operate on her 19 times. 19 times. Same lady. It's different areas. She's really well now. She's doing really well now. But it's interesting because I'm operating on her, Michael, and I'm in the midst of doing something to close her, and she goes, I said, am I hurt? She goes, oh, no, no. I took my hands out of her mouth. She says, my calf pain stopped. I go, come on, don't give me that stuff. Well, I keep hearing that stuff. You know, my calf pain stopped. Susan could immediately breathe. And also her shoulder, she could lift her arm up or do something with her shoulder. I mean, I got a PhD in anatomy. This stuff isn't supposed to do that. Cindy was a 42-year-old Caucasian married hospital administrator from Lima, Ohio, my hometown. She was referred by her infectious disease MD. I love this guy. You know what he said to me? He says, why don't the dentists recognize these things? Do they realize these people could die with this if it gets into the temporal bone and gets to the floor of the sinus and the sphenoid bone? I love this guy. She'd had left mandibular pain for, that's supposed to be 1.5 years. Even though 18 and 19 were treated with root canals, she developed left anterior temporal pain, and mandibular pain was constant. Her chief complaint was severe lower jaw pain, extreme fatigue. She had a sour taste. Her physician placed a PICC line that's misspelled. A PICC line, which means a catheter in her arm here, clear up threaded through her vena or through her subclavian vein down into her heart, directly into the heart. This lady was dying. Her husband's a veterinarian. He couldn't understand why dentists didn't recognize the problem, let alone believe in cavitations. As a doctor, he did. All the positive things. You've seen this before. There it is. There it is. See the horizontal, dentist, see that horizontal thing? That's the size of the lesion. Look at the cavitat scan. Look at this. Michael, you think you got a problem here?
Just a little.
Yeah. Look at this. Here she's scanned 6 months later. Now listen, I'm watching, this is 6 months. Now I'm still going to watch this area here, but her MD and I agree we're not going to do anything right now because she has absolutely no pain. The line is out, she's back to work. It's amazing. Kathy was a 47-year-old Caucasian married businesswoman. She owned 3 computer companies. She began to develop right posterior mandibular pain. Numbers 30 and 31 had been treated with onlays 15 years earlier. She'd taken birth control pills 29 years earlier, just for a short time, because she developed phlebitis in the deep veins in her legs. Still suffers today from it. She sits a long time. She was a chronic bruxer. Her chief complaint was dull, aching pain in my right lower jaw. To make matters worse, she's my wife. How'd you like to do this, guys? Positive x-rays, all this stuff, everything is positive. Here's what it looks like. I mean, listen, I was trained as an anathologist. Dentists know what I mean. I tattooed people. I used a Stewart instrument. Here, that's an anathologist occlusion. Beautiful. Tripodization, everything here. Look at this. Can't even see anything there. Look at this right here. Look at this abscess right there. Look at all this side. This is my wife. Now listen, here's the killer about this. David, look at this. This is not that bad on here. I can guarantee you this is going to be bone marrow edema or focal osteoporotic marrow defect. That's what it is when it's that small. Beautiful onlays. I extracted number 30. Here's the second. Look at this. I reflected tissue. Look what I found here. Now, I'll always remember this for two reasons. One, it's my wife, and two, we were doing this as the World Trade Center was collapsing. Yeah. Look at this. This is where I extracted two, then the other two. Look at this. So did you see, remember how that thing ran from medial to lateral? This is how it's going, medial to lateral right there. Here's the infraalveolar nerve. Now, those don't bother me anymore. But you got to understand, I got to sleep with this woman. I mean, I could potentially make her numb the rest of her life. And I got to move this nerve to clean this thing out. Would you like that challenge, Michael, on your wife? Well, on your former one, you'd love to do this, wouldn't you? You'd probably clip that thing, wouldn't you? That's right. Focal osteoporotic marrow defect. Now, I re-scanned her 6 months later. I'm sorry for this bad scan. Look at this. Look how good this is looking. 6 months later. There may be something here. See? I maybe should have taken that tooth out. I have to wait and see. What? Yeah, maybe. I don't know. Madeline was a 41-year-old Caucasian dental assistant from Cleveland. She had right posterior mandibular pain for 2 years. Pain was persistent, so guess what? They did root canals in the second and first molar, but her problem continued. Number 30 was extracted, and guess what they did? Took the tooth out and put an implant in there. That makes sense, doesn't it? Guess what? Her pain continued. She had a sour taste. Her chief complaint was constant jaw pain. Her pain was constant but varied in intensity. She also was experiencing referred pain to the right posterior maxilla. She ultimately was diagnosed with trigeminal neuralgia and was on medication for this disorder. She couldn't walk. She was on all this medication. Yes, sir?
Did they put the implant in immediately, or did they let it heal?
Oh, they put it in right away. I talked to a guy, I did a lecture one time. He says, what's wrong with putting implants in those places? I said, what happens if you put it in, you feel it's loose? Well, I just put a bigger implant in. Duh. Take a look here. Now, I have to say again, mechanically, the guy did a great job on the root canal. He did a good job. I'm not trying to be funny here. I'm really not. This mechanically is good dentistry. Look at this. Good dentistry. But look at this right through here. See how this goes along here? Look at this. I took out that tooth, and look what I found right here. A big hole. Look at this. There's the infraalveolar nerve right there. Took off a lot of bone. Yes, sir. Yes, sir. Did I have it on there? I don't remember if I did or not. No, that just goes to the midline. These are tori, and this is probably an abnormality. Because I re-scanned, you'll see here in a minute. That's not on there.
Do you see anything on the other side?
Oh, on the bones? Yeah, probably right here. And maybe right here. See those horizontal lines? Right there? Again, I got to tell you, I left the implant because look at this. The scan looks pretty good. I left the implant there. But you see the horizontal bones, the lines there? I'd almost bet that the same thing is going on over here. Now my wife's starting to develop the thing on the left, like the right. You'll find if you treat these patients, when you get one area fixed, they may feel something somewhere else. Open her up. There's we got this. Closed her up. Ischemic osteonecrosis. Now, here's a scan over. Look at this. Michael, look at that, buddy. Look at that. 6 months later to the day almost. That's what she came and look what she had. See?
You surgerized 89-year-old patient?
The oldest was 87. And her name was Olive Grove. No kidding. Olive Grove. Linda was a 59-year-old rider from North Carolina. Right mandibular deep aching pain for 8 years. She took cortisone and birth control pills in the past. Tooth number 31 was treated with a root canal. Pain continued. 30 was treated. Pain continued. That's the way they do it. She had brain surgery, but unfortunately, her pain persisted. This is not uncommon. Yes. Yes, sir.
What is it you think is actually, and then this is my question, I don't know if that's about this, but one, what's causing it, and two, if you think about why the pain is on, three, the pathology or the inflammatory cells?
There are few, but not a lot. That's what's unusual, and that's what throws these fellows off. It's generally because there's not a lot of infiltration of inflammatory cells, which you would think. Now, if it happens to be an open wound to the mouth, there are a lot more inflammatory cells. But if it's never been opened up, there's not. Because the real reason is this. Once there's occlusion, especially in the postcapillary beds, blood can't flow. So even inflammatory mediators cannot get in there as cells, as macrophages, as mast cells. So what? Well, I think it's a chronic irritation, number one. It's almost like a pain generator itself of the trigeminal nerve. Because what's happening is that you've got a very anoxic, ischemic, and probably acidic problem going on here, which is almost like I would just say like a hot poker just sticking the nerve. It's just there all the time. And then, well, and secondarily too is you have a pressure in there. Yes, and what you do is you actually do an osteotomy. You open it, you take the whole buccal plate off, you take it off. Then you scrape the whole thing out. I tell people it's like if you got a hole in the drywall here. You got to fix that hole. You got to cut into the good drywall to fix the bad. Same thing with the bone. You got to go clear down to good bone. Like Mike said, the white bone. Yes? If the nerve's running in there, absolutely. That would cause pain as well. Yes, sir? No.
Wait a minute. That was only done for the study. It would cost a fortune
Yeah.
to the patient, about $500 a location, just to do biopsies. I did that just to prove that it was for real, that the cavitate actually worked.
Here's what it looks like on the X-ray. Again, any dentist in this room, you'd be a liar if you told me that didn't look okay. But look how big this lesion was. Now, you have to understand, some of these go clear up into the coronoid process. You have to really get up there.
You take the inferior umbilical canal, the inferior roof right out.
Yeah, oh yeah, all the time. Well, sometimes you got to actually pick the whole neurovascular bundle up. I use a Sickle Explorer and get in there and lift it up and move it to the side and clean all the bone around.
Use a big number 8 nerve.
Number 6 to 8, yes, but when I'm near that nerve, I'm using hand instruments. Yeah. Again, not that bad, but you can see based upon her history, based upon the fact she had a relief anesthetic blockade, based upon this right here. Here's what it looks like. Opened her up, look at this. There's the infraalveolar nerve right there. Now, here's the artery, here's the nerve, here's the lingual cortical plate, and the buccal plate as I've cut it down, and here's the where number 30 used to be. That's what it looks like. So to back up. Chronic non-suppurative osteomyelitis. I'm almost done here. Karen's a 41-year-old Caucasian married CPA from Louisiana. Number 30 was treated with root canal. Retreated. A crown was placed, yet pain persisted. 30 was removed because her pain continued. Her chief complaint was my jaw hurt. She reported constant deep aching in the right posterior mandible. She had taken birth control pills for approximately 12 years. Again, take a look here. Look at this. Again, you can see this is not normal. This is not as bad as some of those maxillary ones you saw, but you can see with the green there's a little bit of living tissue, but all this means there's ischemia here. So it looks like, open her up, look at this. Now look at this. I didn't take a tooth out there, by the way. That's the way it was. Look at this hole. That's where a tooth was. Like Susan said, where a tooth was. See? Chronic non-suppurative osteomyelitis. Susan was a very mature, single Caucasian writer from Colorado. She had a history of multiple cavitational surgeries in the past, but she continued to suffer with chronic fatigue, had a genuine concern about the development of cavitations. Fortunately, she wasn't experiencing any specific orofacial pain. This is, look at this.
How mature was she? What was she at?
Oh, buddy, she was mature. The problem was I couldn't get her to shut up enough to put my hands in her mouth. No, I'm just teasing. Just teasing. Just teasing. Look at the right side. Oh, I recognize that. I love the betadine. That's what she looks like. Look at this. Right up in there. Now, what I'm showing you here, if you're a dentist, you know what I'm doing. That is a disposable, small suction. That thing, what I'm showing you is probably 1.5 inches up in her maxillary sinus. The first thing I had to do is get a root tip out of there. Let me tell you a story about this. Susan, obviously you know who this is. Susan was in my office, and she was the very first patient I treated after I got the Cavitat. And I scanned her 3 times. I said, this cannot be. I'd never seen this before like this. And we started to talk, and we took our time with her, and you know, obviously Susan and I had become friends, and she was delightful in our office and everything. I'm not a touchy-feely guy. I don't like guys who are touchy-feely. I don't like weepy guys. I wept. I wept when I saw this. I could not believe, and if you as a dentist treat these patients and haven't come to that point, you will. You cannot believe that you've got to take these teeth out of these people that look perfectly good. Her teeth were beautiful. She looked great. And I got to tell her she got to take these teeth out. Have you hit the point yet? Have you hit that wall like that yet?
Yeah, I've scanned many like that.
Did you have that emotional feeling?
It's hard to talk to them about it.
Yeah. Yeah, as hard as you are, Margolis, I bet you have, haven't you?
Many a time.
Yeah.
The one that was the worst is one that came in who had cancer, and I told her I really couldn't help her, but she came up and said, you're my last hope. So you need to do the surgery. By the way, I'm being sued by your husband now. 1.5 years after she died. And yet I advised against the surgery.
Yeah. It was a sad day. I understand, Mike. I do. It was. I mean, my surgical assistant. I just cried. It's so stupid. I don't do those things. I felt like an idiot. I don't do that stuff. I'm a martial artist. Martial artists, they bruise on the inside. They don't bruise on the outside, right? I don't cry. And I tell you what, that was terrible. Look at this. There was no bone up there. Those things were floating in a sea of connective tissue. There we are. Happy couple there. I had to send this lady back to Colorado with no teeth. We had no idea it'd be this bad. No idea at all. Oh.
So what do you do for teeth afterward?
Well, generally I talk to the family dentist, and I have an interim or partial or a complete denture placed when I do the surgery.
And the dentures will stay
Oh, yeah.
when there's no bone in there?
Are you a dentist?
No, not at
Oh,
all.
yeah. Hopefully they will, yes. And it's kind of nice, too, when you do an immediate denture, the dentist will tell you, because it puts pressure on there and also stops the bleeding.
Okay,
Yeah.
thank you.
You're welcome. Thank you for asking. You've asked such good questions and comments. I thought you were a dentist, really. I won't hold that against you,
I
see?
don't want to be in that field.
Oh. Yeah, see, the dentist has to look at this, my dental colleagues, as an oncology surgeon. Except, fortunately, most of our patients don't die from this problem. I said most. I've lost 8 to suicide. And one guy shot his wife, then shot himself. So, but you have to be radical. I didn't used to be radical till I got the Cavitat, and the problem was I had about a 50 or 45% success rate in surgery. My orthopedic colleagues tell me that's outstanding for this problem. If I had a 45% chance I'm going to make it back to Columbus on a plane tomorrow, I wouldn't fly, right? Now our success rate's about 85 or 87%, or better. My surgical assistant says better. I won't know till I really pull my patients. Yes, ma'am. How soon? I would rather never do it. But the problem is, if you come to see me and you've got no anterior teeth when you walk out of my office, I don't think you want to fly back on a plane or drive home without teeth. I try not to put anything. First of all, generally, this is the exception, not the rule. Generally, you don't have to take out all the teeth. Secondarily, if it's 1 or 2 teeth, I try to talk to them not to do anything. However, some people are vain, and I understand that. I'm not criticizing. Especially if they've got to go to the office or see people, we'll put an interim partial denture in that their dentist has made for them ahead of time. So I usually put it right at the time of surgery. But it's not real hard. It's not like compressing the tissues. It's just lying on the tissue. Yes, Kerrie. Or Bobby.
Kerrie, is progesterone to stimulate osteoblast activity?
Nope. Nope, won't do it. That's one of the problems they got. They've been taking something like that. It's got blood vessel swelling. Okay, I think we're going to stop here. We're about done. And there's just too many other things here. We'll stop. What I want to tell you was, if your patients are taking some of these supplements, doctors, you've got to remember, listen, I'm a believer, I'm becoming more and more a believer of supplements, naturopathic way to treat people. However, look at this. If you got a patient that's taking ephedra, a lot of people are, and in some of those things it's called Ma Wang, you know, and some of the, you better get them off that before surgery because that increases blood pressure and heart rate. Ginkgo biloba, there we got it, Susan. Ginkgo biloba, it decreases platelet aggregation. They'll bleed. I did a patient, I didn't take her off the ginkgo biloba, and I thought I hit the aorta. No kidding. She was a mess. Garlic also decreases platelet aggregation, and so does ginseng. These are all common things people buy at store. Kava kava produces sedation, so if you're going to IV sedate somebody, you better get them off kava kava at least 48 hours before surgery. St. John's wort reduces the effectiveness of NSAIDs and anesthetics and narcotics. By the way, well, vitamin C, get them off vitamin C because that will, you have a terrible time with local anesthetics. They do not work well with vitamin C. Dissociation of the molecule doesn't work well. And also by the fact, NSAIDs also interfere, as you know, with healing, but the bleeding continues. Now, I want them to bleed afterwards, but when I'm doing the surgery, since I'm not using the vasoconstrictor, I don't want them bleeding. They'll bleed some, but I don't want them bleeding. So we as doctors, no matter what your degree is, you have to talk to people in your history. People don't think that over-the-counter medications or supplements or herbs are drugs. They do not think that. They think Demerol is a drug, Valium's a drug, but they don't think ginkgo biloba is. They don't think kava kava is. It is. So they have to understand you've got to get a good history on these people, because if you don't, I'm telling you, the first time you do a surgery on somebody taking ephedra, their heart rate's going to be up, their blood pressure's going to be up, and if they're anxious at all, you're going to have one heck of an unmanageable patient. And then if you by accident do any kind of intravascular anesthetic injection, you've got a very excitable, perhaps a CNS depressed patient with a problem. Yes, ma'am. Well, you know what's interesting? Virtually nothing. I know you don't believe me, but the problem is these the nice thing is these people rarely have pain. Isn't that right?
Oh, it's strange that they don't have a lot of pain. Wes and I both use an anodyne light, which is an infrared. And heck, I just had a friend who had rotator cuff surgery. I went over with one of my anodyne lights. He was taking 6 pills a day after putting on the light. He didn't take another pill.
Yep.
So, I mean, these things, there are some things that will reduce the pain.
I try to get them to use the anodyne before and after surgery. I was just showing you, I culture all surgical cases. I biopsy everything, including teeth. Also, use the anodyne after surgery, and they take it to the hotel or take it home. They apply it 20 to 30 minutes every waking hour. You can't see this, but do not put ice on these people. Every one of us were taught to put ice on injuries. You put ice, you slow down blood flow. You may re-precipitate blood clots in the vessels. No ice. And I'm showing you, this is my wife. I'm showing you just to show you, this is fascial space bleeding here. Space down through here over the platysma from up here where her surgery was. I don't care. At least I didn't put ice on her. Postoperative management, soft foods with broths and soups for 2 to 3 days afterwards. Irrigate the surgical wound with iodine or Lugol solution or salt water swished, and oil of oregano. Thank you, Susan. Oil of oregano is an outstanding bacteriostatic, as Royce brought out this morning. I use it all the time with people now, thanks to Susan. I give every patient a water pick. I buy water picks in lots of 36. Every patient gets a water pick. I can buy these things for $24. So every person gets a water pick, and I have them irrigate with iodine solution afterwards, and our success rate has soared. They eat something, drink something, they irrigate. Postoperative medication, somebody asked about this, surprisingly little. Extra strength Tylenol, Ultram, I like Ultram for something stronger. Darvocet maybe. Homeopathic remedies work very well. Naturopathic remedies as well, herbs, supplements. Glucosamine and chondroitin sulfates, you got to put them on that. It's a wonderful healer of connective tissue. Antibiotics, this is the last thing I'll say. What's the criteria for prescribing these things? These are the criteria. Elevated body temperature greater than a degree, fluctuant swelling, cellulitis, mitral valve prolapse, or prosthetic joints. I do not use antibiotics, but rarely. I have friends that do. I'm not criticizing. I'm just saying I rarely use them. I rarely have to use them. These people don't require them. And again, my surgical success is as good as Mike's. No evidence that antibiotics are needed if these things aren't there. Okay. We've got a question and answer session now.
Well, we don't, you actually have until 6 o'clock.
Oh, I didn't know that.
Yeah, you do.
Oh, these people won't hear anymore. Yes, ma'am.
Okay, so you've been doing this type of surgery since '86.
Yeah.
The whole data on like root canals and everything is you don't want to do it, and the whole tooth-body connection. Have you looked at like the teeth that you've taken out in order to do the cavitational surgery, and like later on, what's the effects on these organs with these teeth?
I haven't, because I haven't looked at it that way that long. I've only looked at it that way for a year. And unfortunately, most of my patients fly or drive to see me. So I don't see them again ever if they're doing fine. Now I'm in the process right now, in the next few months, I'm going to send out a questionnaire, which is a blind questionnaire, so I won't know who they are, so I won't prejudice their comments. And we'll find out. So I may find out I have 19% success rate. I don't know. But I doubt that. I think I have a lot better success rate than that.
Because I'm thinking, okay, great, so we have success rate on the bone, but then they drop dead.
Right. I don't know. That's a great question. I don't know. But you got to understand, I would consider myself as an integrative doctor because I'm integrating allopathic and naturopathic things together.
Right.
I'm not ashamed to say this is new to me when it comes to body organ kind of things or tooth organ kind of things. Mike's been at it a lot longer than I have. I'm learning, and I'm getting more and more aggressive on that. But if you knew more about my background, you know why I'm this way. I have to prove to me it's right before I can teach it or do it. Because if I ever have to defend myself, I want to say, the literature says. That's why if you ever read any of my papers, I've got a voluminous amount of references, and you saw the references I put here too. Yes, sir. Thank you.
What do you do for vasoconstriction when you do have bleeding?
Okay, you're asking now a question out of school. What do I do for vasoconstriction? Well, first of all, if I got an artery or a vein, if I can clamp it, I clamp it. That's rare. Pressure, almost always pressure for a short period of time, a minute or two will stop it. Even the inferior alveolar, believe it or not. If that doesn't work, I'll use pressure with a cholestat or collagen plug. If that doesn't work, I'll use epinephrine. Don't you tell anybody I said that. But those of you watching this video who are purists, if you've never done that, you're a liar. Yes, sir.
I'm wondering,
Or you're not doing surgery.
terminology, but this business about reversible flow is sympathetic versus parasympathetic. My background is actually cardiovascular surgery. I was wondering, rather than an actual true reversible flow, could it be that the sympathetic is really clamped down, and of course, everything cycles from sympathetic to parasympathetic.
Sure, sure.
The sympathetic releases to become a parasympathetic increased flow. You may actually have, what they call it, post-perfusion. What, in essence, what happens when you increase the flow, you actually tremendously increase the free radicals.
Right,
You've got
that's
a
right.
ischemic environment.
That's right.
Now you oxidize the whole antioxidants pathway. So then you get edema of the tissue. So you have chronic tissue edema.
That's right.
But I mean, it's not a true reversible.
No, you're excellent point. Steinman didn't get that far, and you know as well as I do that in 1960 those kind of things weren't known well at that time. And so that's probably what it is. I've not had time to personally do any kind of further research on it or anything, but you're right about that. And who can say, really? The concept is, though, acceptable that Price and Steinman demonstrated there is a flow available or possible through the dental tubules. Now, is it an autonomic problem? Is it a free radical thing exchanging or changing the polarity or some, who knows? I don't know. Your point is excellent. I don't know. I can't tell you. My point was going to be, though, there is a flow, where a lot of people don't even think about that.
Well, there's reperfusion ischemia, reperfusion happens in open part, it happens in any kind
Sure.
of clinically order to do it this high. You know, you hurry to do it, but as soon as you open it, what's happening is the increased arterial flow in washes out all kinds of toxins that damage the
Sure, sure.
body, but I would think blood, you should probably run pulses for sympathetic
Mhm.
parasympathetic. That's one of the ways you do reperfusion of demons, how you do it.
I'm- I'm going to, I appreciate that. I'm going to contact you later and ask you to talk with you about that. Because you're a surgeon, aren't you? He's a medical doctor. I want to talk to you about that because that's a very interesting point. And maybe, not maybe, I know you can teach me. I want to know about that. Thank you for that. Seriously. Yes, sir.
Yes, has Dr. Price's experiments been redone or duplicated with rabbits, and what were the results? Or has it not been done, and why not? What's the story?
I'm sure Peter would love that experiment today. You know, I don't know. I really do not know. Yes, Michael.
Didn't Hal Huggins redo it all the things?
Yes, you know he did.
He did. He
Yep.
went through and he got the identical results, and of course, everybody's told Hal that he was crazy. So,
Well, he may be crazy if he got the identical results,
he
too.
got identical results, all of them beautiful.
The most common postoperative complications I see quickly, alveolar osteitis, dry socket. These people, they're prone to have it like Susan told the guy. I've had dry sockets. My friends, if your patients tell you these things, listen to them. I have trouble with anesthetics. Listen to them. I can't take that much codeine or whatever. Listen to them. When I first got out of school, of course, I didn't because I knew everything. Now I'm beginning to learn. Right? If your patient says, I can't take them, then believe them. If I get dry sockets, believe them. Temporal tendonitis, pain in the temple, the ear, all that kind of stuff. Zygomandibularis tendonitis, that's a muscle that was recently described or discovered, causes pain in the anterior temporal region. Myofascial pain. I don't want to continue on here because you've got too many questions, but alveolar osteitis, they have a deep aching, swelling, fever, sour, foul taste, pain radiation along the mandible or maxilla. Diagnose it by examining it, doing anesthetic blocking. Treatment, you simply irrigate, start bleeding. I suture it up. Home irrigation, I give them a syringe to irrigate at home with. Have them change their diet, quit eating so much junk that gets stuck in there. If you smoke, don't smoke. And appropriate medications. Temporal tendonitis, this is the temporal tendon right here. These people come back to your office and they've got ear pressure and pain and tooth pain, and the coronoid process is tentative palpation. You definitely have temporal tendonitis, which is probably caused by having their mouth open during surgery. Painful palpation of the coronoid process, and if you anesthetically block the coronoid process, the temporal tendon there and the pain stops, you can bet it's temporal tendonitis. Very common after surgery when their mouth's open. Inject medication. I use Serapin, which is a non-steroid anti-inflammatory, and Marcaine without epinephrine. Soft diet. I make an appliance called an NTI, which makes them quit clenching at night. And I put ice and moist heat outside. Give the injection like this. Zygomandibularis tendonitis, they have anterior temporal pain, orbital pain, mandibular pain, and palpation of the zygomandibularis muscle, which is right here, right in front of the temporalis muscle. Here's what it looks like right here. Just discovered. Here's what it looks like on an MRI, or a sagittal section on the Visible Man Project for NIH. That's what it looks like right there. Again, that's what it looks like right there. Huh? Yeah. That's what I love to do, though, you know. Painful palpation of the tendon, successive anesthetic block, treated just like temporal tendonitis, identical. Myofascial pain, they have muscle spasms after surgery from having their mouth open. They have a reduced range of motion of the jaw or their head and neck, by the way. You can eliminate pain and increase range of motion with the Vapocoolant spray. Trigger points feel like little BBs. This is not a course on that. You can treat it by all kinds of ways right here. This is where chiropractic is so important right here. I cannot work without a chiropractor. I love chiropractic. I try to get my daughter to be a chiropractor, but she's in nursing instead. Let's see here. See, trigger points of the temporalis muscle can make a person think they got a toothache. How many root canals I've seen done here when the problem was up here? An NTI, and I'll be all done. An NTI was approved by the FDA. I happen to be the lead investigator in this study. An NTI looks like this. Looks like this. That stops people from clenching and grinding. It's extremely effective for tension-type headaches and migraines. Ooh, watch out where that thing lands. We're probably going to need it. A man or a woman can make the same mistake day after day and call it experience. Those are my wieners. My wife's a lucky woman. She has 2 wieners at home. There's Heidi and there's Oscar. Thank you very much.